First thing, we completed an assessment, speaking with the teams, the directors, the nurses, as well as the physicians. Did some patient surveys as well to figure out what their strengths, weaknesses, opportunities, and threats were. And we definitely prioritized them based on the threats. The number of patients left without being seen was identified as an opportunity to jump on immediately. And that is a direct reflection of your front-end process. So we have metrics in the emergency department that we break down into 3 phases: the front end, the middle phase, and the back end phase. So we started with the front end so that we can capture those patients in the lobby. We changed the traditional process of triaging patients, old school process of obtaining medical history, medications. What happens is throughout the United States, emergency departments have made that triage portion a tedious process and long process before getting to the physicians. Our primary responsibility, or our primary goal, is to get the patient in front of the doctor as soon as possible. And the way that we do that is we remove non-value added steps in the patient's processes or in the clinical processes. And so removing those non-value added steps is decreasing the questions that we ask, only the pertinent questions to make a decision on whether you need to be seen by a physician or not. Can you be seen by a mid-level provider? That mid-level provider is important to our vertical processes. And what I mean by vertical is every patient that comes to the hospital does not need a bed. What they want to do, though, is see the physician. Can they see the physician in a chair, upright status? In that case, we divert those patients to what we call our rapid assessment zone. In that area, we shift, and that was one of the major things that we did, one of the major changes, was shift our providers to the front end of our process. So seeing that provider in less than 10 minutes is our goal. That provider will do a medical screening exam and enter orders. Once they enter those orders are carried out by a tech on site immediately. And then once we get our labs off to the respective places, then we can make a decision. By the time the physician comes to the bedside, then only after he's completed his assessment, will then make a decision on whether this patient needs to be admitted or discharged. Again, our goal is to decrease our ED overall length of stay.